Hello. Let's talk about vasculitides. This should be a quick one. So a vasculitis is a localized inflammation and necrosis of a blood vessel. And I say localized because it's going to be a segment of a particular vessel. And then it's going to be due to a circulatory cause. So you're going to get these little patches of vasculitic localization all over your body. And based on whether it's a large, medium, or small vessel vasculitis, well, you'll see it in those sized vessels. And they'll each come with their characteristic constellations of symptoms. So inflammation and necrosis inside the wall of a blood vessel is typically going to be mediated by our immune system because we have monocytes and neutrophils and lymphocytes, T cells and B cells that float around in our bloodstream at all times. And then they're attracted to these chemical signals kind of emitted by areas of injury. And whenever that happens, we know that endothelial cells upregulate certain surface receptors that allow for immune cells to bind there and extravasate into the tissue underneath that endothelium. And in the case of a large artery, well, the damage is going to be in the wall of the artery itself. And so those immune cells are just going to stay right there because that's where the damage is. And so you've got some sort of etiology causing a inflammation within the wall of a blood vessel, and the immune system reacts to it and sends all these different types of cells there to attempt to quench it. But because these vasculitides are typically autoimmune in origin, they don't really go away, because normally your immune system finishes the job, washes its hands, and it's done. You don't have any more local inflammation in wherever that infection just was. But if it can't clear the injurious stimulus, as is the case with a small vessel vasculitis, especially because that's immune complex deposition, and it's really hard to clear those systemically. Once it gets started, you're never really going to be symptom free until you can control the swelling. So we're thinking about the role of the immune system in the vasculitic pathology. And normally, like I said, the inflammation is self-limited, but in the case of an egregious autoimmune cause, it'll just continue. And all of the neutrophils and macrophages, we know that they contain these destructive enzymes, and they're going to keep releasing those enzymes because they think that there's a pathogen there, but there's not. It's usually an autoimmune complex. And due to the release of all of these destructive and lytic enzymes, that's what causes the tissue damage in vasculitis. That's what causes the propagation of the erosion of the wall of a blood vessel. And what this manifests as symptomatically is end organ ischemia and or hemorrhage. Obviously, both of those, ischemia is going to be clotting and hemorrhage is going to be an aneurysm that bursts within a blood vessel. And those are your two big roots of endothelial damage, blood vessel damage. So how do we classify the vasculitides? Well, the easiest way to do it is primary or secondary. And primary means that we don't know why you have a vasculitis, but then secondary says we can take a pretty good guess as to why you have a vasculitis. And secondary vasculitis is almost always associated with infections or drug use. There are some prescription drugs that can cause a reactive vasculitis, or it could be an illicit drug use. And secondary vasculitis is going to be the most common variant of vasculitis. It far outnumbers primary because there's just so many different things that can give you a secondary vasculitis that the odds that you just kind of catch one of those from the environment is a whole lot greater than the odds of you happening to develop a pure vasculitis, a primary vasculitis. And the differentiation between primary and secondary is going to be the first thing you want to do as a clinician when you get the suspicion that a patient does have a vasculitis, or whenever you see all these symptoms associated with different vasculitides, such as the livedo reticularis, or maybe you start seeing a whole bunch of nodules. Those are indicative of immune complex deposition within capillaries, and then they leak, and then the red blood cells stick together after they leak out of the blood vessel, and they clump and they form these tiny little microclots, and you get a bunch of those in one place, and that's an immune nodule. So you're trying to differentiate primary versus secondary, and you're going to do that usually by tissue biopsy because you don't know for sure until you take the biopsy. And lots of these present non-specifically. And there's also lots of overlap, particularly in medium vessel vasculitis. That's kind of not really a category in itself because you often see some large vessel vasculitides begin to encroach upon the medium size. And then some small vessel vasculitides, your immune complexes, your type 3 hypersensitivities, those can get stuck in medium vessels too. So I would say really you're going to be clued into, is this a large vessel, is this a small vessel? And the symptoms that you see are going to be fairly specific to either of those cases. And so we're going to take a slice of a particular artery, and then we're going to drop some stains on it particular to the pathology that we're thinking, and whether it lights up with that immunofluorescent stain or not is going to clue us in and say, okay, this is for sure a Weger's disease, or this is for sure Henoch-Schönlein purpura, and so the diagnosis depends on what we stain it with. Epidemiology, non-specific, nothing big there. Thinking about the clinical findings, they're going to be symptoms of generalized inflammation. And remember, we said it's an immunopathology. It's inflammation in the blood vessels caused by macrophages getting in there, neutrophils getting in there, lymphocytes getting in there, and really messing things up. And so because it's immune mediated, well, your immune system travels in your bloodstream, which goes to every organ system. And so many of these vasculitides can have broad presentations and non-uniform presentations because who's to say what's going to be the first end organ to go, So the skin is a good place to start because the skin, you have a lot of skin, it's got a broad surface area. And so vasculitides do tend to present with dermatologic components first and foremost before patients notice any other manifestations of end organ damage. And within the skin, you've got this thing called a livedo reticularis, which is going to be characteristic of a medium vasculitis. And it's essentially a bunch of clots that form in the walls of your medium vessels. And because they're close to your skin, these things form in medium veins a lot because the flow of venous blood is very slow compared to arterial blood. And if you've got this immune complex that's, a shape of an antibody antigen welded together, and it decides to get stuck in a wall, well, it's more likely to get stuck in the walls of your venous system than your arterial system, simply because the flow is slower there. And so whenever this happens and damage accrues in the walls of veins, well, those veins can start to appear a lot darker, and they will appear darker because that's red blood cells popping open and spilling their hemoglobin, or that's clumps of red blood cells, and so that dark coloration reflects that there's some damage going on in those vessels. And then palpable purpura, which is very similar to nodules. Both of those are kind of the same thing. They're going to be type 3 hypersensitivities in which there's an immune complex deposition, and they kind of clump up and stick to one another and form these beads within the skin right underneath the surface. Ulcers and gangrene are characteristic of a couple, particularly Thromboangiitis Obliterans. You see this also with Raynaud's, but that's a vasospasm, not a vasculitis. And then, as you can read the table, all of your other organ systems can get involved. This is typically only going to manifest symptomologically after it's progressed pretty far, So the skin symptoms are very important because you can see the skin, but you can't see your kidney and you can't see your gut. So if you've got these immune complexes depositing in the small arteries of your kidney or gut, if you're the patient, you have no idea until it's kind of too late, until you've already had a broad range of necrosis due to all of the immune cells just doing their thing and trying to get rid of that injury. And so that's the take-home message of the first couple of pages of this SDL, and they apply to both of the vasculitis SDLs, and that's that the physical diagnosis is particularly high yield, and most of the time you can make the diagnosis of vasculitis. You can make a specific vasculitis diagnosis based on physical symptoms alone, so pay attention when you're looking at that and understand that the dermatologic symptoms are going to be our first step in narrowing it down. So Understand that whenever you get some monocytes that crawl into a tissue, they've got to be activated to become macrophages, right? And they can become activated to become M1 or M2 macrophages, right? And normally, you know, if a monocyte just crawls through a blood vessel, that doesn't do any damage at all. And if a monocyte gets there and it's not activated, you know, that's not doing any damage at all either. And if a monocyte gets into the wall of a blood vessel and it decides to become an M2 macrophage, well, then that's not going to do any damage to it. That's anti-inflammatory. But the concept behind all vasculitides is that there are these immune cells that are extravasating into the wall of the blood vessel and they're becoming activated in a pro-inflammatory manner. So we're thinking our M1 macrophages. So obviously there's going to be a lot of TNF alpha, interleukin 6, maybe some interleukin 1 floating around, and they're going to be activated because cells are responding to whatever local injury, be that antibodies or otherwise, is causing them to pop off these pro-inflammatory molecules. So the reason I bring this up is because we typically treat vasculitides with immunosuppressive therapies. And often that's going to be your MABs, that's going to be your cyclophosphamides. So the clinical side of managing a vasculitis is, I would say, a lot higher priority than just the diagnosis side, because anytime you're playing around with immunosuppression, you know, you have to monitor that patient pretty regularly. It's a high risk treatment. So again, you get a lot of neutrophils, and especially in the small vessels, that's the next SDL, but small vessel vasculitis is a type 3 hypersensitivity 99.9% of the time. And so remember that that's going to be an antibody response to usually an exogenous factor such as a pathogen, a protein expressed on the surface of a pathogen, maybe the shape of a particular drug, and whatever the bug or drug is shaped like is coincidentally going to be shaped like a specific cell surface protein expressed somewhere in your body. So whenever your immune system makes antibodies, B cells make these antibodies that are anti-shapes against the shapes on the pathogens or the drugs. Well, then if they are shaped like something on the surface of a cell somewhere in your body, well, then you just got an autoimmune reaction. And if it's a reaction to something that's floating around in your bloodstream typically, well, that's called an immune complex formation. Because if it were to stick on the surface of a cell, you know, that would be like antibody-dependent cellular cytotoxicity. That would be a type 2. But we call it a type 3 whenever the antibody generator, the antigen, is soluble and floating around in the blood. And so when that happens, we make the antibodies against the antibody generator and they bind. And because this is occurring in the bloodstream and not on the wall of a cell, you know, this thing just keeps floating around in the blood. And then it will just lodge somewhere and stick in the wall of a blood vessel. And when it does that, you know, well, it's going to be signaling for inflammation. And it's also going to activate the complement cascade, and the ability of an antigen antibody immune complex to activate the complement cascade is really important, you know, because the complement cascade just kind of kills cells one small little poke at a time, you know. And specifically C5a is chemotactic for neutrophils and for macrophages. So that explains why an immune complex directly leads to a swarm of immune cells following it, trying to clear this immune complex, because there happens to be a lot of complement 5a around it. So complement 5a being chemoattractant is a really big concept that is applicable to all of the vasculitides we'll see in the next SDL. And moving on from here, a little bit about ANCAs. We'll skip that, talk about that next SDL. We're moving into some specific diagnoses. First, there's Takayasu Arteritis, and we're going to keep this short and sweet. It's called pulseless disease because you get a stiffening of the aorta, and so less blood It's called pulseless disease because their peripheral pulses go away, and it's involved with the aorta, and it produces this end organ ischemic damage. It's mediated by natural killer cells and cytotoxic T lymphocytes, and so that's a way to test all of these different diagnoses. Is what's the immune cell you expect to see on histopath, because they're all immune related, right? But they're going to have different immune cells involved in different conditions. So in the case of Takayasu's, it's anti-cell cells, you know, the ones that get in there and destroy cells. And the way that natural killer cells and cytotoxic T lymphocytes do this is through the perforin granzyme pathway. And remember, perforin just basically makes channels within the membrane of one of your living cells. And then granzyme is this enzyme that gets flooded into the cell. And granzyme is going to activate the extrinsic cascade. Try saying that 5 times fast. So it's going to activate the extrinsic cascade, namely caspase 3, and that's going to activate apoptosis. And so that's the direct mechanism of the damage in Takayasu arteritis and any other time you see cytotoxic T's involved. And this damage and this lymphocyte intrusion is going to be occurring in the walls of the aorta, and that's really notable because Takayasu is the only vasculitis that is going to involve the aorta the majority of times. Where are they at in the aorta? Well, the T cells are in the adventitia. Cell death typically occurs in the media because it's a big media in the aorta. You can get a tree barking appearance, which you'll also see in syphilis. But if you've got syphilis instead of Takayasu's, then, well, before you get the tree barking aorta, you're going to see some maculopapular rash on your hands and feet. And then you could also see this thing called a condyloma lata, which is like a wet, kind of slimy fish scaly thing around the genitals or mouth. And then you could also see this thing called a gumma, which is like a syphilic gumma is like, you know, those candies dots that like they used to give out on Halloween, and it's like a really bad Swedish fish. It doesn't taste like anything in particular. That's basically the consistency of a gumma. So that's how you differentiate syphilis versus Takayasu. Going back up, Takayasu is going to be female 80% of the time, and it does present fairly early, so you get these kind of young females like around our age right now, and then they'll be presenting with these symptoms involving, and the symptoms are going to be like claudication, number 1, could be like really cold extremities, number 2, that reflects blood not getting down to your distal extremities. Could be unequal blood pressures. Maybe their dorsalis pedis is going to be intact, but their radial pulse is not going to be, something like that. You can hear bruits when you auscultate, and you got to be careful to not mistake that for a heart condition. But namely, those are going to be the main symptoms. Is they're going to come to your office and they're going to say, okay, I'm really sore whenever I'm doing these things involving my upper extremities. And when you take the pulse, you realize, holy cow, they barely have a pulse in their wrists bilaterally, you know. And that's the characteristic presentation of Takayasu. If it gets really bad, it can lead to a stroke. It can lead to congestive heart failure. And on imaging, I highlighted this specific angiogram on the right because, well, that aortic aneurysm is a bad complication of Takayasu, but it would also be the degree of complication which could show up on an x-ray, you know, and I think an x-ray is a nice, easy thing to give us at this point in our careers. Basically, it's aortic stenosis, as you see in this second square. That's the subclavian artery that's stenosed. Or I'm sorry, no, that's a 7-year-old's aorta. And yeah, you can tell that it just gets really, really, really narrow, and then it starts to widen out again. So anytime the aorta is involved, you're thinking Takayasu. Let's get into giant cell arteritis. Patients have headaches. Patients may have vision loss. You treat it with steroids. That's GCA. There's a predilection for the DRB1 0401 human leukocyte antigen allele. And the inflammatory cells that you're going to see in a giant cell arteritis or temporal arteritis are going to be the same varieties that are in the Takayasu's. You're going to see a bunch of lymphocytes, macrophages, and you're going to see giant cells as well. And that's one last thing to mention about Takayasu's, is that you might see giant cells in the wall of the aorta. But this is called a panarteritis, giant cell arteritis, is because it means that every layer of the vessels is affected, the intima, media, and adventitia. So that differentiates it from a lot of things. Right here is an example of giant cells in the right picture. On the left, that's an internal elastic lamina that's just split open. And if you ever see that on a biopsy, you know it's a vasculitis, because it's an inflammation inside the wall of an artery, right? And it's localized. So the symptoms of a giant cell: headache and jaw claudication. Both of those are very common because this tends to present in the arteries of your neck and head, and it's typically not going to present lower than that, although it may. But the headache and the claudication are noteworthy symptoms. And then obviously, if there's any visual loss, the patient is going to immediately run to your doorstep, and you're going to have to keep a suspicion in your mind for a giant cell arteritis when you're working it up, because you need to treat it immediately with glucocorticoids, as we've heard 20 times by now, I'm sure. So polymyalgia rheumatica is kind of this twist on giant cell arteritis. And polymyalgia rheumatica, what does that mean? Okay, lots of myalgias, lots of muscle pain, and it involves the joints, rheumatica. And so this is going to be joint pain in the limb girdles, the big joints, and it's typically going to occur in the morning and be symmetrical. So if they have this abrupt onset, abrupt offset, joint pain and ache, specifically it's an ache, and it is symmetrical, plus they have this headache or this visual disturbance, well, then that basically confirms giant cell, not in real life, I would say, but on a test question where giant cell is an answer, then that basically confirms giant cell. And one more time, you're going to see a lymphocytic predominance if you do a joint biopsy. So it's going to be some sort of serous inflammation because it's not infected, but then you are going to see a high lymphocyte count in there. And when you see a high lymphocyte count inside a joint, well, what's more likely? Bilateral large joint viral arthritis or arteritis, so I'm going with the vasculitis there, most likely, thinking it's an autoimmune disease, if not. So going into polyarteritis nodosa, the noteworthy things about this pathology are, number one, there's a strong association with an antecedent hepatitis infection, be it B or C. And I've seen that worked in the question stems a lot. And then number two, polyarteritis nodosa tends to inflame preferentially the gut and the kidneys. And so this is something that really may not present until it progresses and becomes pretty bad, and so characteristic signs and symptoms of this, characteristic lab work is going to be proteinuria. There might be occult blood in the feces. Polyarteritis nodosa, the name derives from the fact that patients have palpable nodules, that's the nodosa, and then polyarteritis affecting multiple arteries. And the hallmark of this disease is aneurysms, and that's because they look like nodules. They're not nodules, they're outpouchings, they're balloon-like inflations. But if you get an angiogram, they look like nodules. So again, the gut and the kidney most often infected. Did see a question. One question I saw was patients got diffuse abdominal pain, so very vague presentation, but then you procure an angiogram and you see right renal arterial thrombosis and then left renal focal aneurysmal dilations. And what's going to cause focal dilation, like beads on a string type of appearance? Well, the only other thing that comes to my mind right now is fibromuscular dysplasia, but depending on the symptoms, that abdominal pain clues you into a vasculitis. And the question was, which serology would you see in this patient? And the answer was it Hep B surface antigen, because that's the one that stays elevated even after Hep B infection resolves. So keep your eyes open. Anytime you see Hep B in the answer of a question stem on this upcoming test, it's going to be referring to polyarteritis nodosa. So a common way for polyarteritis to present is with mononeuritis multiplex, but I've seen a couple question stems that did not include any neurologic involvement at all. So know that this is a really common presentation of polyarteritis nodosa, but it is not by any means, it's not something that will be there, you know. So if a patient's got these non-specific GI symptoms without the mononeuritis multiplex, you can't rule out PAN. And then going on down to this chart, we see that the most common clinical manifestation of PAN is going to be, you're going to get an arteriogram and angiogram, and it's going to show aneurysms or focal stenoses, typically within your GI and kidneys, right? So that's, we're thinking about our different mesenteric arteries. We're thinking left and right renal arteries there. You see that in question stem. That's the most common presentation of polyarteritis nodosa. There's no diagnostic lab work, but again, what could you see in blood? Hep B surface antigen, Hep C titers. So again, on imaging, we're looking for aneurysms on imaging. It could also be a region of stenosis, but typically it's going to be these saccular fusiform microaneurysms, predominantly in the renal, mesenteric, and hepatic artery branches. That's it. This paragraph right here, yo. This paragraph right here is what makes polyarteritis nodosa on a question stem most times. So we're looking at the pathology. What do you expect to see on pathology? Fibrinoid necrosis. You will not see granulomas. You will not see giant cells. You're going to see these microaneurysms. Of course, you could see a small aneurysm even on a histopath slide, and it would probably be filled with a lot of blood, and that would be ruby red, you know, compared to the pink of an H&E stain. But fibrinoid necrosis, what does that look like on H&E? Well, I've got it in black and white here, but you can zoom in, and even when it's in black and white, you can see that there's this big, thick region up at the top here that just doesn't have a lot of nuclei at all within it. And so it's a relatively acellular area, right? And it kind of extends, and you've got these big acellular patches elsewhere inside the tunica of this vessel. Like, look, here I'm outlining an area in red, and there's like 2 nuclei in that whole area. So if you're looking at a healthy blood vessel, then that tunica media, because remember, this is going to be like a medium-sized artery disorder, it's going to be packed with smooth muscle cells, and all of them are going to have nuclei. And so if you see this really, really, really pink region that's relatively anuclear, then that tells you, okay, this blood vessel is not very healthy at all, and it's not healthy to the point of being dead, and that's fibrinoid necrosis. And then we look at this kidney, and then this is another way to tie it into our hypertension lecture. You think that's going to be a low or a high renin hypertension as a result of what's going on in their kidneys. And I would say that this is probably going to be a high renin, because with all those aneurysms, you know, you're going to be knocking off your glomeruli, and you're going to be, if there's this stenosis occlusion going into the kidney, you know, well, if there's a stenosis going into the kidney, it sees that as a low blood pressure, so it pops out a lot of renin to compensate. What's the worst case scenario for PAN? Congestive heart failure, aneurysmal rupture, obviously. And then here in the text, GI hemorrhage and perforation. So those are complications. Now let's get into Thromboangiitis Obliterans. This is also called Buerger disease. And once you just Google images this pathology or look at the photos in this text a couple of times, you're not going to forget it because it's so distinctive. You get black, blue fingertips, ischemic digit ulcers if it progresses to that, or even digit gangrene and gangrenous necrosis. And what you see on histology is microabscesses. And if you ever see microabscess in the context of a histology question stem, it's most likely referring to, on this test, Thromboangiitis Obliterans. So it kind of looks like Raynaud's. We know Raynaud's. What is Raynaud's? Well, it's going to be vasospasm of the distal digital arteries, and it's also going to make your fingers turn blue. And the populations that get both diseases are fairly different. Raynaud's tends to be women, Buerger's tends to be men. And Buerger's is almost always going to be someone who smokes a lot of cigarettes. It's very, very heavily correlated. I saw one question that was simply, what's the treatment for Buerger's disease? And the answer was not, it was not corticosteroids, it was not antibiotics, it was stop smoking. And then if you slice open a blood vessel and take a biopsy, you're you're going to put it on a slide, and you're going to see neutrophils with karyarexis, and you're going to see microabscesses. And those are two characteristic findings of Buerger's. And when you pair that with the fact that one of their fingers or toes looks similar to this, it's an easy diagnosis to make. So I want to go over neutrophils with karyarexis. What is karyarexis? It means that the nucleus of that neutrophil is starting to fragment and split apart. And so you can see this alternatively phrased as fragmented neutrophils in a question stem, or they could say, what would you expect to see on histology? And one of the answer choices is leukocyte fragmentation. So just use your brain and understand that they're going to try to tell you with words what you ought to be visualizing is happening down there. Anytime you see neutrophils popping open, well, why are they popping open? Usually it's because there's some sort of immune complex there, or some sort of agitation to the arterial wall that makes it so that those cells just pop. What's the most appropriate treatment? Smoking cessation, that's in the text. And corkscrew collaterals, I did see this come up too, is sort of a buzzword. So anytime you see digital corkscrew collaterals, you're thinking Buerger's. Then we get into Kawasaki disease. This is going to be children the large majority of the time. It happens more often in Asians. It can affect the heart, and specifically it can give you a coronary artery aneurysm. Most times it's self-limited, meaning it goes away on its own, but about 1 in every 5 cases, it's there for a while. And this can be a very bad disease because this can cause death in infants, and not infants really, but peds. This can cause a kid to just die at age 3 or 4, you know. So it's kind of a stalwart on boards for that reason. It's typically preceded by a viral infection, and then this is going to give you some sort of autoimmune pathogenesis. And Kawasaki disease patients typically have some sort of HLA that predisposes them to a particular infection, and none of that is specified within the text. But how it presents is a fever, and you're going to see the fever always. Every Kawasaki question stem, they have to have a fever. And the mnemonic for Kawasaki's is crash and burn. And that's because, like, Kawasaki, that's the K, crash with a K, and then they get a rash, and then they burn, and that's a fever. So you're going to see a young girl, maybe a young boy, high fever and rash, and they might give you an angiogram on a question stem that goes down and looks like this. And what's this? A bunch of aneurysmal outpouchings of the coronary arteries. Obviously, that is super bad. Other symptoms, there's the exanthema, that's the rash. Erythema, again, reddening of the distal extremities, that's the rash. Diffuse maculopapular rash on the trunk, that's the rash. You could get a conjunctivitis, and again, cardiologic findings are kind of worst case scenario for this disease. They're not there in most patients, but when they are there, you need to pick up on them. Inflammation is going to be involving all of the layers of the vascular wall. What was that? Panvascular was the word we used earlier. And then it's typically going to be self-limited. But the questions that could arise out of this Kawasaki disease section, I think, are going to be the type where they say, what would you expect to see on histology, or what would you expect to see on an angiogram, something like that, because there's just not that much to go off of here, and the diagnosis is fairly self-evident. So that's it for the vasculitides. Next lecture, we're going to get into the onco-related vasculitides, and there's a bit more to talk about with those, but I'm appreciative that this first lecture was fairly brief.